This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hi, this is Tesha Monteith with the Neurology podcast. I'm back with our November special podcast series in headache medicine. Today, we'll be providing an update on CGRP inhibition and integration into clinical practice. I can't think of anyone better to discuss this with than Peter Goadsby, Professor of Neurology at the University of California, Los Angeles, and Director of the NIHR Clinical Research Facility in King's College, London. Hi, Peter. How are you? Thank you so much for joining us.
Well, thanks for asking me. Always a pleasure.
I remember when arenimab, the first CGRP monoclonal antibody, was announced. I remember what I was doing. I remember who I was talking to.
I remember the first prescription I wrote for aranimab. It felt weird to be writing a prescription for a medicine that I'd been interested in for almost my entire professional career. It was a very weird experience, I have to tell you.
So let's talk about that. Let's talk about the road of CGRP inhibition in clinical practice. What more do we know from 2018 or even beyond that?
I think one of the lessons of the CGRP era, if I could say it that way, and it's not that long yet to be an era, but I think in retrospect it'll be looked at like that, is the underestimation that we've made in clinical trials and sometimes in clinical practice, but I think almost more in academia, and there's a reason for this, the underestimation of the importance of tolerance as well as efficacy, tolerability, that is to say, as well as efficacy in the use of preventives. We've typically used monthly migraine days, headache days, 50% responder rates of the same, and measured efficacy. And we can show many of our older drugs work quite well. The percentage of population who respond are quite good. However, if we ask them whether they like the drug, well, they can barely answer the question with some of the side effects that they get. And I think that we missed a trick in not being much more intentional and attentive to the importance of efficacy married with tolerability. At the end of the day, a person has to live with the medicines we give them, and we don't want the consequences of that to be so troublesome that the benefit get outweighed by the side effects. So I think that's the great lesson, the whole package. And the way I do that, I think we all do it in clinical practice. When someone comes in and you look at them, the first thing you more or less ask them after you said how they are or, shoot the breeze a little bit is, how's it going? What's it like? Where are we going? That sort of thing. Everyone has their way that they say it. And what that's captured in now in clinical trials, of course, is patient global impression of change, which is just a fancy way of saying how you're going, and has a marker. And if you look at studies, there's a very nice study that Patricia Poza-Rosic and the Spanish group published to show that the thing that absolutely predicts maintaining aranimab, for example, therapy at 12 months is patient global impression of change, unsurprisingly. And I think that this move to patient-reported outcomes and really being attentive to the needs of our patients, that's probably one of the meta messages from the CGRP era.
So I hear you about safety. I think that's hugely important. And, efficacy as well. And you say that they're married together. Is there any biological predictors of CGRP response?
Well, none that I know of so far. It's rather disappointing in that way, or frustrating for clinicians. I love the fact that I can see someone and prescribe CGRP pathway medicine. I hate that they go away with reasonably high expectations and a group of them are utterly disappointed. And I don't know how to do better with that. But it is certainly one of the challenges, since the pathway's pretty clear, the target's pretty clear, and the outcomes are pretty clear. It should be one of the challenges we take on in the next 5 years or so to work out a little bit better who's going to respond better. That would be good for everybody.
Yeah. And in addition to who's going to respond, walk us through how you choose a CGRP inhibitor, which one to use, either one of the monoclonal antibodies or now the GPANs.
Well, the first thing is what's available, because you can only choose from what you have, number one. And number two is, if it's available, is it prescribable? What I mean by, is it prescribable? Is it on the formulary? Is it on the insurance formulary? Is it on the national formulary? Is the person going to be able, if it wasn't on the national formulary, are they of means to be able to purchase it? Can you actually do it? Because there's no point telling someone about something that they can't have. That's just cruel and inappropriate. So the first thing I try to do is understand what it is that's available for the individual who's involved. And then I think it's quite important to set out the options rather than tell a person what to do. Because I think as much as I'd like to think I try to get to understand patients that I see, I never cease to be amazed by, when I present the options, that they go for an option I wouldn't have guessed they would have done that. So I kind of set it up on it like a shelf that they have in the CGRPs, that they have first the monoclonals, 3 ones that you can inject yourself once a month, or one of those you can inject once every 3 months, or one you can get an injection into the vein every 3 months. Okay. And you've got tablets, and the tablet ones you might take every second day or might take every day. Fundamentally, the response rates are not much different, so obsessing about that is not going to help anybody. And the side effects are modest and, broadly speaking, comparable. Now, if someone's got poorly controlled hypertension, I don't use that as an excuse to change monoclonal. They need control of their hypertension. I mean, must never forget doing the basic medicine properly. If someone's got GI problems, they may or may not think that mild constipation is an issue. I certainly have quite a number of patients who've gotten constipation from various of these medicines and are perfectly happy with the medicine and would prefer to use prunes or some other laxative because they're so well. We should never underestimate how dreadful migraine is, and it's shouldn't be surprising to us that a person will want to persist with the medicine even if it's got some mild side effects. Indeed, we've done that in the past years. So I set up the options and see where they're headed. Most people will have a decision based on what someone else told them, what some relative told them, what someone down the street told them, maybe in the US, what they saw on the television. They'll have a view, and I'll be able to sort of pick that view so that they get the thing that they actually want, because a priori there's not much reason to take one or the other. And if I'm forced down a road, I'm going to be simple. I think basically the choice is between, do you want to inject yourself once a month or do you want to take a tablet? And if I can't get an answer out of that, then it is going to be about what can I easily prescribe. And in some places in the world still it's only the monoclonals. In some place it's the tablet. And try and understand it. I think most people have a preference. And if they select the thing that they want, they'll do it. And if they do it and you've got compliance, you'll get exactly what it says on the jar, because these things perform as well as they do in the clinical trials, in my experience. So you'll get what you can expect. I think listen to the patient is the answer to what to use first. What's going to happen, of course, is that we're going to be anyone who's tried a GPANT as a preventive, who's failed, very reasonably, we're going to give them a monoclonal, and vice versa. And you'd think that would be a useless pastime, but it's not. There's plenty of real-world evidence to suggest you can swap from one monoclonal to another and pick up a percentage of people, maybe 20%, who weren't responding, and you think, wow, that ought not be the case. And from an intellectual point of view, it's frustrating, but from a clinical point of view, it's just great.
How do you switch? Take us through how long you keep a patient on a prophylactic therapy. Does it differ from the orals? And when do you decide to switch?
Well, switching is driven by a couple of things, and again, it'll vary in people's practices. For some people, I think switching is simply to do with what their follow-up time is. In many of the government-run systems and even in private systems in the US, the follow-up time is quite difficult, because if you can't see someone for 3 months, well, you're not going to be able to switch anyway. Broadly speaking, I think 3 months is perfectly is pretty much a minimum. You can see from early work we did with some of the monoclonals, from the nice work that the Italians have done, a nice multi-center study where they looked actually at what happens if you continue on treatment. It was a really nice study. Pierre Barbanti is the first author, and they looked at the group of people who hadn't responded at 3 months, who continued on the same thing for another 3 months, and about half of the non-responders responded in the second 3 months. So it's a pretty good study. They had nearly 700 or a little bit more than 700 participants in the study, so it's a decent size. Now, that said, I think at 3 months you have the conversation. If there's any hint that something's going on, then that multi-centre study would suggest you should push a little bit longer and try and get out to 6 months. And then you can be pretty sure that you're not going to be moving anywhere. I think that partly is the reason why when we swap at 3 months, for example, from one monoclonal to another, that some people respond in the next 3 months, not because they change, but because simply the longer you expose someone to this mechanism, the more likely they are to respond. That's one of the sort of intellectual things that we might try to sort out in the next few years as well. From a patient's point of view, like, so what, so long as they're responding. So I think somewhere between 3 and 6 months is a reasonable place, and the Barbanti data is a good way to argue that.
So beyond the clinical trials, the pivotal clinical trials, you spoke about this long-term study. What other long-term studies or real-world studies do you think have really kind of shifted views and clinical practice?
I think the real-world studies that we've seen from our Italian colleagues, from our German colleagues, from our Swiss colleagues, have all pointed to a theme that if you treat people for 12 months and then you stop, then a substantial group, more than half, maybe 2/3, will revert in their frequency. And what they say is that it's not unreasonable at the 12-month mark to ask yourself for a patient to continue. You have about a 2/3 chance of getting worse and a 1/3 chance of staying well, more or less. And it's an approximate number to have a discussion around. And that means whatever decision you take or the patient takes, more importantly, is correct. Because if they're worried about it coming back, I can see why they want to continue. If they want to try to stop, that seems perfectly reasonable. Faced with those sort of numbers and what we've seen, and in 3 separate studies done in separate countries, same outcomes broadly speaking, I think continuing is pretty reasonable. And the largest group of patients I have who, when we have this discussion, want to continue. And then something we were talking about earlier, is that so surprising? We say migraine's a horrible condition. We say it's horribly disabling. People lose time, they lose function. It interferes with their life in many, many ways. We say that, and then we say to people who are well controlled, would you like to try being like that again? I mean, it's like someone saying to you, if you've got a broken leg, would you like to try it again? What a great idea. I'll just break your leg and see how we go. But I think it's reasonable when patients look at you and think, well, no, I'm really well. My life's really great. I'm back at work. Everyone enjoys it. Things are really great. Why do you want to rock the boat? So I'm in the be patient camp. When at 12 months, I'll say what I know about the data, and if a person wants to continue, I think that's perfectly reasonable. For how long I'm going to continue to say that, let's get some more time, more to go under the bridge. We certainly haven't run into any long-term side effect issues, so there's no immediate downside to that. And there's a lot of upside because you've got people functioning normally in the community and happy, and that's exactly what we want.
Yes, I totally agree with you. And I think Richard Lipton says it well, that these drugs are not disease-modifying drugs. As well as they work so well, and patients can go literally down to headache freedom, they're not disease-modifying. So you stop them, and naturally, because migraine is a cyclical disorder, some people are going to be in remission, but others are going to get worse. And so we have to remember that.
The drugs are life-modifying.
Yes.
Because if you lose a day today to migraine, you're not going to get it back. You're never going to get it back. So in terms of your functional life, they actually prolong your functional life. And we talk about, disease modifying, and I understand that means what happens afterwards. But I think disease course modification is something they do, since every day a person is functioning normally when they wouldn't have been functioning normally is an extra good day of their life. And I think we should frame the conversation a little bit like that from the point of view of the patient who's got more days and society who's got this functional member of the community back together. So I see a half glass full aspect of it, the disease course modification that's happening with these drugs.
That's a really nice way to take a look at it. So let's just talk a little bit more about some real world observations. It's helpful in the setting of medication overuse, headache. It's wonderful. Seems to have an additive benefit with onabotulinum toxin A. What about the combination of the monoclonal antibodies and GPANs. We're seeing that a lot more, this dual therapy.
We are, and that's, I mean, again, you wouldn't have started out thinking that was a good idea at the start. You would have think to yourself, well, everything should be covered. But the pharmacokinetics predict that. There's a nice predictive paper, Kilbasser, I think, and Helton encephalalgia a couple of years ago, 3 or 4 years ago, which looked at the behavior. They looked at levels of galcanezumab and plasma and CGRP and saw the dip and then the recovery of CGRP over the 3-month period between treatments. They were using 300 milligrams at the start. And then they did some nice modeling, which shows that whatever the dose is, you don't end up flattening, at least theoretically with the modeling, you don't end up flattening the CGRP level in the body because it ends up with an equilibrium at a lower level, but with an equilibrium. And of course, that's panned out now in the phase 1 studies. There's a nice phase 1B study with ubrogepant and erenumab, or ubrogepant and galcanezumab, which shows that the ubrogepant pharmacokinetics is not altered at all, plasma concentrations with either of those medicines, and you don't see any more adverse events. So the modelling, phase 1 and real world data all point to what I think is broad clinical experience, that there's no downside to trying a GPAN on top of a monoclonal, or indeed trying a monoclonal on top of a GPAN that's being used for acute treatment.
Or even a GPAN and a GPAN, something like a Toshapant on top of an abortive. I know there will be some clinical trial data that will be later presented.
Yep, exactly.
So let's just talk about tachyphylaxis, and then let's talk about the non-responders.
Well, when we talk about tachyphylaxis, I think we're referring to, say, people who are stable monoclonal responders and then the thing stops responding. Is it tachyphylaxis, or is it a change? Is it the disease itself evolving? And you could think of that in practical terms as the same thing, but I'm not sure it's pharmacology so much as disease evolution. And if I've seen people now with migraine over a couple of decades, and they go through good periods and bad periods, and you see them in the bad periods, and you don't see them for 5 years, and then 6 years, and they pitch up again, and everything's been fine, then it's not fine. I've seen that happen with all of the classic preventive. So I think much of what we're seeing is as much the disease changing itself, disease course, as it is a change in the pharmacokinetics, pharmacology of the CGRPs. I don't think it's something that's unique to CGRP. It's very frustrating for patients and physicians, and we change our therapeutic approaches. Sometimes you change monoclonal. Sometimes you can add in an older preventive to try and change things, to try and get on top of things. I think it's about disease change as much as it is anything else.
Absolutely. And so let's also talk about, you mentioned these older drugs. Let's talk about how you approach the propranolols, the topiramate, the antidepressants, the nutraceuticals. And of course, it's a patient conversation and shared decision-making. But in your mind, how do you see these treatments?
Now, I grew up, so to speak, using the sort of medicines that we're talking about there as the staples. And like anything, you don't realise how troublesome they are till you have something better. My first go-to of the, I'd say classic or the non-specific preventives, if I could use a term that way, is candesartan over all the ones that you've mentioned, because it's a once daily dosing. There's no weight gain. There's no cognitive effect. There's no sedation, apart from a little bit of dizziness with maybe 15% or so of people is generally well tolerated. So it's my first thing to go to. It's utterly frustrating in terms of what the mechanism of action must be. So I tend to, firstly, most of us in neurology or in headache specialist practice will see patients who've had one or other preventive usually. It's unusual for someone not to have had, say, globally to have had propranolol, because the most commonly used preventive in the world, or in the US topiramate, because that's the number one prescribed preventive. So we usually don't, I'm very happy not to have to go back down that road. And it would be really exceptional. I can't remember the last time that I wanted to go back down that road. But I will tell them about about the use of candesartan. Of course, these are off-license discussions, and we should say that to listeners that there are 2 randomised placebo-controlled trials with candesartan, but it's not licensed, so that I want to be really clear about it. Other non-licensed things that can be useful, memantine, for which there's one placebo-controlled trial. Other non-licensed things, melatonin, for which there's a nice randomised controlled trial compared with amitriptyline, which it outperformed. So I think that, if one knows you need to know about these broader, older things, be able to have the conversation with people who, say the insurance people say that you have to have failed 3 things to get a monoclonal. It's not catastrophic. I mean, it's reasonable to have the conversation and kind of move on. I don't sit there looking like the world's going to collapse because I can't just go straight to a G-pen or a monoclonal, because it doesn't inspire any confidence in the person sitting in front of you to go, oh, woe is me. Oh, this is hopeless. I have to give you something hopeless. I'm not sure it helps. The other use drugs that have some reasonable track record, that are reasonably tolerated, and I'm happily surprised very often that we can make some progress. But I'm not a big user of particularly topiramate. So I think that can be very unpleasant when the side effects sit in.
And what about, let's talk about the abortives, the G-PANs in comparison to the triptans. Obviously, we still have the NSAIDs. We have one Ditan, lasmiditan. So what is your approach there?
Well, it's mostly about realism. A medical system that would allow everyone who needs something to get the thing they need is a reasonable system. And if that means some people get a triptan and it works for them, I'm not going to cry over spilt milk. I think, if you push the fast forward button and the price was the same, then more people would start with a G-PAN, because it's simply a simpler choice to use than a triptan. I'm pretty reassured by the 2 post hoc meta-analyses that the G-PAN folks did, one with rimagepant and the other one with ubrogepant, that showed that people who are naive to a triptan are more likely, in both groups, for ubrogepant or rimagepant, are more likely than placebo active, because they're post hoc analyses from the placebo control trials, more likely to respond. But also current triptan, if you take a current triptan user, if they take a G-PAN, they'll do better than placebo. And happily, if you take people who failed 1 or more triptans, they'll do better than placebo. So if a person's happy with a triptan, why rock the boat? If you have to prescribe a triptan, it's not catastrophic. They've been around for 35 years or so. We know a lot about them. We've got all the randomized trials. You can build on them. I usually would start with sumatriptan because all the others were compared against it. And then if a person doesn't like it, they can tell you why they don't like it, and you can work it out logically. And if you started with the G-PAN, that wouldn't be catastrophic either. You would do quite well. It's largely constrained by what's available. And then, of course, whether there are any contraindication. There aren't too many real clear dyed-in-the-wool contraindications to a triptan. So I think we're going to be using triptans for the foreseeable future, at least my foreseeable future.
So what would you say to some people, and we sometimes guide people that, the idea of treating early for migraine, wait till the pain is mild, but for some people that have higher frequencies, that could mean using a lot of triptans. So what do you say to maybe some critics that would have concern about using a pharmaceutical during a non-headache moment?
I think up till we had G-PANs, that was a very perfectly reasonable concern, be that with triptan medication overuse, or even with non-steroidals causing GI symptomatology. Up to the advent of the G-PAN, perfectly reasonable thing to say. In the G-PAN era, I think it's a very different proposition. It's pretty clear that from the preventive studies that if you take atogepant as an example every day, you don't get more headache, you get less. And in fact, there was an abstract I was involved in at the International Headache Society that looked at an individual patient level at increases in headache frequency in the placebo versus the actively treated atogepant group. And more patients in the placebo group during the treatment phase had increases in their headache frequency than did the atogepant treated group, which says this idea that you can make things worse clinically doesn't seem to be panning out. In the laboratory, we've shown indeed that you don't get sensitization in the experimental animals with repeated use of a GPANT, whereas you do with a triptan. That's been shown specifically for ubrogepant by Frank Parecco and his colleagues, and for alsegipant by Phil Holland and colleagues at King. So there's good basic science for this, and it's panning out in clinical practice. And then you look at things like Noel Rosen presented some very nice prescription claims data that showed that on the introduction of rimogepant use, the use of opioids reduced. I mean, the use of opioids reduced. I mean, I think it's pretty clear, whatever way you sort of cook the goose, so to speak, to cook the turkey, I probably should say, given our recording date, it's pretty clear that these drugs don't make things worse. In fact, second daily use of rimogepant makes things better. Daily use of atogepant makes things better. I understand the concern. It's historically reasonable. It's part of the evolution of our field. This is just not something that's manifesting with the GPANT. So, no, I don't think it's a concern. And because the evidence is the more you use these drugs, the better you get. So, good.
I think this is really important conversation. And we really also need to talk about equitable access to these treatments that, as you mentioned, are life-saving, saving so much time. So let's talk about equitable access and health disparities in migraine.
Well, there isn't equitable access. Whether you start with the clinical trials, there's a demographic in the clinical trials which has been the same for the last 30 years, and it's not a demographic that reflects certainly anywhere where the studies were done. I don't want to criticise anyone in particular, but it's not, I'm not criticising the companies, I'm not criticising any individual investigators. It's the system, and the system is not well stacked for the disadvantage. It means that the access to these medicines is severely restricted away from people who, if they can't function properly, it's a different implication for their life. If you have to go to work, and we all have to go to work, but if missing a day's work is about getting bread on the table, piece rates and people who are paid by the hour or by the day, that's more than just I had a bad day. That's my whole family had a really bad day. My kids had an unfair day. I think that health disparities that affect migraine, because they affect families and they'll affect, let's say it, they're going to affect single mothers because migraine affects more women. And the single mother who's got 2 or 3 children and needs that day's work, who only gets half a day's work or misses a couple of days' work, there's a whole downstream effect of that. And I find it really quite disturbing to think about how much that person suffers and then how much they suffer in the broader context, because they have that kind of, they've got the whole guilt thing, they've got a lot of burdens. Mm-hmm. And for a simple, relatively straightforward treatments that we have, I don't know what the solution is, but I think the problems are really can be heartbreaking, really.
Yeah, and I think conversations are really important, because if you don't have that conversation, eyes don't open, there's not awareness, and there's not maybe change in policies down the line.
Yes, I know that Rami Burstein is incoming International Headache Society president and is quite exercised by getting certain migraine drugs on the World Health Organization absolute necessary list. And more power to him for trying to do that. Because you might, again, one thinks that it's part of the problem of migraine. Oh, no one dies. Fine. But people's children suffer because the consequences of migraine for their parents. That's just totally wrong. And as our abilities to improve therapy are advancing, surely we have an obligation to make sure that those improvements are seen by everyone who could benefit from them. And not only do the individuals benefit, but the entirety of society benefits from making sure that everyone has a reasonable access to good treatments for migraine.
And you say no one dies, but, I think Ann Scherer published on this many years ago about the downward mobility associated with migraine. And we know with downward mobility, there's decreased access to healthcare, education, all of these social indicators that are associated with increased morbidity. So I think the research, we need to do the research.
I agree with you. I just hate to think about children who just don't get a decent meal today because of the financial constraints and the difficulties of migraine within a house. I think it's just wrong.
So I've listened to many of your lectures by now, and you always have a hope part of it. And so you're no pressure to you, but you're the sixth expert on our series, and I want to end with some hope. So what are you hopeful about?
I'm three things I'd say. Firstly, we're going to understand the disease better. All of the things that we're doing with functional imaging, genetics, what we're talking about, the drugs getting into the CSF, actions on the brain, the premonitory prodromal symptoms, we're getting better at understanding the disease, and we're turning that into new therapy. So I think that's the first thing to say. The second thing is to say we're already starting to see what's next after the CGRPs. We've got pituitary adenylate cyclase activating polypeptide. I'll bet that it's going to be on the podcast next year. Entirely different target, entirely new opportunity. So, you can look at someone in the face who's not responded to anything you can think of, and you can say with hand on heart that the next thing is moving along. So we're definitely going to do better year on year. And the third thing about hope, and maybe it's the broadest thing, is when I look at something particularly like the GPANs, and I look at them when they're off patent and when they're cheap. And when there'll be a day when they're going to be worth pennies. That means the whole world, and I mean all the people who can't afford these things now or can't do, will one day get the benefit of everything we're doing, and that is something to look forward to. So everything is going to get better.
Well, thank you so much, Peter, for being here and sharing all of these updates with us. It's, I think, been really informative and useful to our listeners.
Thank you.
And thank you again for listening to the November special podcast series in headache medicine.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes. Or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.